Imagine this. You wake up one morning feeling that unmistakable heaviness deep in your lower abdomen. You make your way to the bathroom, sit down, and wait. And wait. And nothing comes. You push a little harder. Still nothing. You think maybe another cup of coffee will do the trick. So you get up and try again an hour later. Same outcome. By the third or fourth attempt, something has changed, and not for the better. Now there's genuine pain. A deep, dull, almost pulsing ache that spreads from your lower back all the way down into your pelvis. You start feeling full, swollen, almost feverish, and a small voice in the back of your mind begins whispering, "Something is seriously wrong here." If that scenario resonates with you, if you're watching this right now and that description struck uncomfortably close to home, I need you to set everything else aside and give your full attention to the next 18 minutes. Because what I'm about to share could genuinely spare you from a dangerous, potentially life-threatening medical crisis. My name is Dr. Dan Carter, and today we're having the conversation nobody wants to have, but that millions of people, particularly adults over 60, desperately need. Today's subject: stool that has become physically lodged inside the rectum. What is it? How does it develop? What warning signals does your body send before things become catastrophic? And most importantly, what can you do about it right now, step by step? I promise you, by the time we're finished, you'll understand your own digestive system in a way no doctor has ever taken the time to lay out for you. And that understanding, that's the most valuable thing you'll take away from this conversation. So take a slow breath, settle in, and let's begin. Before we dive in, I'd love to hear from you. Where are you watching from today? Drop your city or country in the comments below. I read every single one, and it genuinely helps me see who's part of this community. All right, let's get into it. And I want to start not with the fix, but with the problem itself. Because here's where most people go wrong. They treat digestive troubles like a dripping faucet. Ignore it for a while, put a bucket underneath, hope it sorts itself out. But what we're dealing with here isn't a leaky tap. This is more like a pipe that is completely seized up. And understanding precisely why it happened is the key to both resolving it right now and ensuring it never happens again. The clinical term for what you're experiencing is fecal impaction. But set the medical jargon aside for a moment. In plain, straightforward language, here's exactly what's going on inside your body. Your large intestine, that 5-foot-long tube that winds through your abdominal cavity, has one essential job: to draw water out of whatever passes through it. It's remarkably efficient at this task, brilliantly so, in fact. The trouble is that when stool lingers inside the colon for too long without advancing, your body doesn't know when to stop extracting moisture. It just keeps pulling water out, hour after hour, day after day. And what started as soft, manageable waste gradually transforms into something with the consistency and density of hardened clay. Now here's the part that blindsides most people. This situation almost never develops abruptly. It's not like a switch that flips from fine to crisis overnight. What typically happens, especially in older adults, is a slow, incremental buildup over 3, 4, sometimes even 7 or 8 days. And during most of that time, you may feel only mildly uncomfortable, perhaps a bit full, perhaps slightly sluggish. You might even still be going to the bathroom, but each time you go, you're only passing a fraction of what your body needs to eliminate. A small amount gets out, but a significant portion stays behind. The next day, the same thing repeats, and the day after that. Think of it like this. Imagine you have a garden hose and you're trying to force a large, rough, irregularly shaped stone through it. That stone isn't going to glide. It isn't going to compress, and the harder you push, the more firmly it wedges in. That is literally the mechanical situation unfolding inside your lower digestive tract. And the harder you bear down on the toilet, the more you're actually compacting that mass further rather than loosening it. But here's what I truly need you to grasp, and this is especially vital for older adults. The older we get, the more susceptible we become to exactly this scenario. After 60, several physiological shifts converge simultaneously, dramatically elevating the risk of fecal impaction. Intestinal muscle contractions naturally decelerate. Pain perception in the gut becomes less dependable, meaning you may not register the urgency signals as clearly. Many older adults take medications: blood pressure drugs, pain relievers, antidepressants, iron supplements, even calcium, that significantly slow intestinal movement. And the natural thirst drive weakens with age, leading to chronic, low-grade dehydration that the body doesn't even perceive as thirst anymore. So this isn't a failure on your part. It isn't your fault. It's a perfect storm of biological changes that nobody ever adequately warned you about. Now I want to spend a moment on something genuinely important, because the symptoms of a fecal impaction can be deeply misleading, and misinterpreting them can lead people to take precisely the wrong action, making everything dramatically worse. The first deceptive symptom: watery liquid discharge. Stay with me here, because this is the one that steers the most people in the wrong direction. You might be sitting there thinking, but I'm not constipated, I actually have diarrhea. And here's the startling truth about that. When a solid, rock-hard mass of stool completely blocks the rectal passage, the newer, looser waste descending from higher in the colon has nowhere to go. So it does the only thing it can. It seeps around the edges of that solid obstruction and leaks out as watery liquid. This is called overflow or paradoxical diarrhea, and it fools people into believing they have a stomach virus or a gastrointestinal infection rather than a blockage. The hazard: people reach for anti-diarrheal medications. And those drugs, the kind that halt intestinal movement, are absolutely the worst thing you can take in this situation. They don't merely stop the liquid output, they slow the entire digestive system, allowing the impaction to continue hardening and expanding. If you're experiencing watery discharge alongside a heavy, aching sense of rectal fullness, do not touch anti-diarrheal medication, please. The second deceptive symptom involves your bladder, and this one catches almost everyone off guard. You may suddenly find yourself struggling to urinate. You feel the urge, you go to the bathroom, but only a painful trickle emerges. Or you discover you need to go every few minutes, yet barely produce anything. This isn't coincidental. Your rectum and bladder are anatomical neighbors, sharing a very confined pelvic space. When your rectum is distended and swollen with a large, hardened mass, it physically presses against the bladder wall from behind, partially obstructing the urethra and making normal urination difficult, or even impossible. In severe instances, this urinary retention becomes a medical emergency in its own right. The third symptom that gets missed is lower back pain, a deep, non-specific aching in the lumbar region that doesn't seem connected to your bowel at all. Many people assume they've strained a muscle or that their arthritis is acting up. But when rectal pressure reaches a significant level, the discomfort radiates outward into the lower back, down into the thighs, even into the hips. If you're experiencing unexplained lumbar discomfort alongside any bowel irregularity, that combination is a warning sign worth taking seriously. And the fourth symptom, particularly relevant for older adults: sudden shifts in mental clarity or confusion. This one sounds peculiar, I know, but substantial clinical evidence shows that in seniors, significant bowel obstruction can contribute to what resembles a cognitive episode: disorientation, mild bewilderment, unusual restlessness. This results from the systemic physical strain and discomfort the body is enduring, sometimes compounded by early toxic accumulation. If an older loved one seems suddenly mentally off without an obvious explanation, always consider their bowel status as a contributing factor. Let me be direct with you now, because I believe you deserve the truth delivered plainly, not softened into language that dilutes the message and robs it of the gravity it deserves. A fecal impaction is a genuine medical emergency, not an inconvenience, not something to ride out. If left unaddressed, the consequences escalate in a very predictable and very serious pattern. Stage 1. The intestinal wall, which is living muscular tissue, becomes severely stretched beyond its functional capacity. Blood supply to that overstretched tissue starts to diminish. The muscle begins losing its ability to contract and propel waste forward. Essentially, that segment of bowel goes silent, what clinicians refer to as an ileus. Stage 2. As pressure continues mounting, the distension can spread upward, affecting higher portions of the colon. What began as a localized rectal impaction can evolve into a broader colonic obstruction. Nausea and vomiting set in. Abdominal bloating becomes visible. The person looks and feels genuinely unwell. Stage 3, and this is the one I need you to hear clearly, is bowel perforation. The intestinal wall has physical limits to how far it can stretch. When those limits are exceeded, the wall tears. And when that occurs, the contents of the bowel, fecal matter, bacteria, toxic byproducts of digestion, spill directly into the sterile abdominal cavity. What follows is a rapidly advancing infection called peritonitis, and it is life-threatening. Without emergency surgical intervention, it's fatal. I'm not sharing this to alarm you. I'm sharing it because the consequences of neglecting this condition are real, and you have every right to understand them clearly. The gap between serious but manageable and life-threatening emergency is narrower than most people imagine. So what does the danger zone actually look like from the inside? Here are the signals that mean you need to call emergency services or get to an emergency room without delay. A rigid, board-like abdomen that's tender to the touch. A high fever exceeding 101 degrees Fahrenheit. Sudden, severe abdominal pain that is constant and intensifying, not crampy and intermittent. Complete inability to pass any gas at all. Unstoppable vomiting. Or any sudden drop in blood pressure accompanied by confusion and cold, clammy skin. These are not wait-and-see symptoms. These are act-immediately symptoms. All right, let's shift from the why to the what do I actually do right now? Because knowledge without action doesn't help you. And I want to provide a clear, logical sequence you can follow starting tonight if necessary. The very first thing I need you to do, and I cannot emphasize this enough, is stop straining. Put the brakes on. Every time you bear down and push hard with a solid impaction blocking the exit, you're not helping. You're increasing pressure inside the abdomen, aggravating already inflamed tissue, and risking hemorrhoids or small rectal tears. Straining will not dislodge a fecal impaction. Not once in the entire history of human experience has sheer force on the toilet budged a hardened mass. So we're going to abandon that approach right now. Step 1. Lubrication and softening with glycerin suppositories. Your first at-home intervention involves adult glycerin suppositories, available over the counter at any pharmacy without a prescription. Now, here's the essential detail most people don't know. For a significant impaction in an adult, a single suppository is rarely enough. The standard approach for a hardened rectal blockage involves using 2 to 3 suppositories at once. One alone simply may not generate sufficient lubricant to coat and soften a large, dehydrated mass. Here's precisely how to do this correctly. First, don't stand up. Lie on your left side. This specific position, called the left lateral decubitus position, aligns the sigmoid colon and rectum in a way that lets gravity assist rather than work against you. It also relieves direct pressure on the rectal area. Next, apply a generous layer of water-based lubricant to each suppository before insertion. Don't skip this step. The tissue inside your rectum is already irritated and inflamed, and dryness at this point makes everything more painful and more difficult. Gently but firmly insert all 3 suppositories as deeply as possible. You want them pressed up against or alongside the hardened mass, not sitting near the opening where they'll simply slip out. Then, and this is the most critical instruction, lie still. You must maintain this position for a minimum of 30 minutes, ideally 45. The glycerin needs time to melt at body temperature, spread, and penetrate the outer surface of the impacted mass. It also needs time to stimulate the rectal wall to increase its own secretions. If you leap up and rush to the toilet after 5 minutes, you accomplish nothing except wasting the suppositories. After your 30 to 45 minutes, rise slowly. Go to the bathroom, and let your body work without forcing anything. If there's movement, wonderful. If not, stay calm. Don't be aggressive. Step 2. Rest, walk, and repeat. If the first round produces no results, give your body a full hour of rest. Stand up. Walk gently around your home. Drink a full glass of warm water. Warmth helps relax the intestinal muscles. Then lie back down and repeat the suppository process exactly as described. A second round is frequently what finally breaks through. The first application often softens the outer layer of the blockage. The second round reaches the core. If you're still here with me and finding this helpful, take a moment to type 2 in the comments. It lets me know you're watching and getting value from this. Step 3. If home measures don't work, it's time to seek help. I want to be unambiguous here. If you've completed 2 full rounds of the protocol I just described, waited the appropriate amount of time, and there's still no movement, or if you're experiencing any of those emergency symptoms I outlined earlier, it's time to go to urgent care or the emergency room. This is not failure. This is the correct clinical decision. At the hospital, The medical team has access to clinical-grade enemas that use larger fluid volumes delivered under controlled pressure, reaching further into the colon to break apart the mass from above. They also have imaging tools to assess just how extensive the blockage is and whether the bowel wall is at any risk. Step 4. Manual disimpaction. In cases where all other interventions fall short, a specialist will perform what's called manual disimpaction. I want to be transparent about this procedure because it sounds alarming, and knowing what to expect removes some of the fear. The physician will physically break up and extract the hardened mass digitally, meaning with gloved, lubricated fingers. In cases where the impaction is severe and the surrounding tissue is significantly inflamed, this isn't performed in a standard examination room while you're awake. You'll be given appropriate sedation or anesthesia to prevent pain and allow the rectal muscles to fully relax. It's a serious procedure, but it's a safe, well-established clinical intervention. And the relief that follows, the immediate, dramatic release of pressure and pain, is described by patients as profound. Clearing the current blockage is essential, but I'd be doing you a disservice if I stopped there. Because if we don't address the conditions that created this situation, you'll be back, probably within weeks. And after the second episode, the third comes even faster. This is how chronic fecal impaction becomes a repeating cycle that gradually worsens with each occurrence. So let's discuss how to genuinely protect your digestive health for the long haul, especially if you're over 60, when the biological factors I described earlier are actively working against you. Number 1. Hydration is not optional. It's the foundation of everything. Water is the single most important variable in preventing stool from hardening. Your large intestine draws moisture from waste as its primary function. If you're not consistently providing your body with adequate incoming hydration, there simply isn't enough moisture in that waste stream to keep stool soft as it travels through. The challenge for older adults is that the thirst reflex genuinely fades with age. You may feel perfectly fine, experience no sensation of thirst whatsoever, and still be chronically dehydrated at a cellular level. The practical recommendation: don't wait until you feel thirsty. Drink 6 to 8 glasses of water throughout the day, including a full glass first thing in the morning before you eat or drink anything else. That morning glass activates what's called the gastrocolic reflex, a gentle wave of intestinal movement triggered by fluid entering an empty stomach. It's one of the most natural, medication-free ways to encourage regular morning bowel movements. Number 2. Movement matters enormously. Your intestine isn't a passive tube. It's muscular tissue that propels waste through a rhythmic, wave-like contraction process called peristalsis. And here's something most people don't realize. Physical movement of your body directly stimulates peristalsis. A 20 to 30-minute walk after meals, even gentle, comfortable walking, has been clinically shown to significantly speed up intestinal transit time. For older adults who are more sedentary due to mobility limitations or chronic pain, even chair exercises, gentle stretching routines, or simple torso rotation movements can help keep intestinal muscles active. Prolonged sitting, especially after eating, is one of the most underappreciated contributors to constipation in seniors. Number 3. Review your medications with your doctor. This one is non-negotiable. A wide array of commonly prescribed medications, including opioid pain relievers, certain blood pressure drugs known as calcium channel blockers, iron supplements, high-dose calcium supplements, antidepressants, diuretics, and antihistamines, are known to significantly slow intestinal motility. This doesn't mean you should discontinue your medications. It means you should have a frank, specific conversation with your physician about your bowel function. Ask them directly, could any of my current medications be contributing to constipation? And if so, are there alternatives with less impact on my digestive system? Many doctors simply don't raise this topic unless you do. You need to be the one who brings it up. Number 4. Exercise caution with stimulant laxatives. I want to address something here that I see cause considerable harm in older patients, because it seems counterintuitive at first. Stimulant laxatives, the kind that chemically force the intestine to contract, are useful in genuine short-term situations. But when they become a daily crutch, something troubling develops. The intestinal muscle starts depending on that external chemical stimulation to initiate movement. Over time, without the laxative, it simply doesn't contract. This is called cathartic colon, or laxative dependency, and it's far more prevalent in older adults than most people appreciate. If you've been using stimulant laxatives daily for more than 2 or 3 weeks, please consult your doctor before stopping abruptly and work together to gradually taper off while rebuilding natural motility through the other approaches I've described. If you've made it this far and you're getting value from this, type the number 4 in the comments. It's a simple way to let me know you're here and following along. Number 5. Establish a consistent bathroom routine. Your body has a natural internal clock, and your digestive system follows circadian rhythms just like your sleep cycle. The gastrocolic reflex is strongest in the morning, particularly within 30 minutes of waking and within 30 minutes of eating breakfast. Use that window every single day. Go to the bathroom at the same time each morning, whether or not you feel a strong urge. Sit down, relax, and give your body 5 to 10 minutes. Over time, typically 1 to 3 weeks, your body begins to synchronize with this routine and initiates movement on its own schedule. Consistency is the training tool. Don't skip days. And finally, posture matters more than you'd think. The human body wasn't designed to defecate from a seated position with the thighs at a 90-degree angle to the floor. Physiologically, a slightly squatted position, thighs angled upward toward the abdomen, fully relaxes the puborectalis muscle, a sling-like structure that otherwise creates a natural bend in the rectum. A simple step stool beneath your feet when you sit on the toilet, raising your knees above hip level, can meaningfully ease the mechanics of evacuation. It sounds almost too simple to matter, but for many people, especially older adults with weakened pelvic floor muscles, this single change produces a dramatic improvement. Before I close, I want to speak to a group of viewers who may not be here for themselves, but for someone they love and care for: an aging parent, a spouse, a sibling. Because fecal impaction is disproportionately common in bedridden or mobility-limited elderly individuals, and the people who spot the problem first are often their caregivers. If you're looking after an older adult who hasn't had a meaningful bowel movement in 3 or more days, who's complaining of abdominal pressure or lower back pain, who seems unusually uncomfortable, confused, or agitated, do not assume it will resolve on its own. The stakes in a frail elderly individual are higher than in a younger, otherwise healthy adult. Their intestinal walls are less resilient. Their ability to communicate the severity of their discomfort may be limited. And the cascade of complications I described earlier can advance more quickly. Proactive measures include offering warm fluids frequently throughout the day, gently assisting with movement or repositioning to encourage abdominal stimulation, using a glycerin suppository early, at day 2 or 3 of no movement, not day 6. And if there's any uncertainty, contacting their physician or bringing them in for evaluation. A simple abdominal X-ray can confirm the presence and extent of a fecal impaction within minutes. Please don't feel embarrassed on their behalf. This is a clinical medical reality affecting a significant percentage of elderly adults in both home and care facility settings. The conversation may feel awkward, but the consequences of silence are far worse. We covered a great deal of ground today, and I want to briefly recap the most important takeaways. A fecal impaction, stool that is physically lodged in the rectum, is not a minor inconvenience. It's a serious medical condition that develops gradually, disguises itself with misleading symptoms, and can escalate to life-threatening complications if ignored. The warning signs to watch for: persistent rectal heaviness and difficulty passing stool, overflow liquid discharge that mimics diarrhea, difficulty urinating, lower back pain, and in older adults, unexplained confusion or restlessness. The emergency response protocol: stop straining immediately. Use 2 to 3 adult glycerin suppositories with generous lubrication, lying on your left side, and wait a minimum of 30 to 45 minutes. Repeat once if needed. If home measures don't work, go to urgent care or the emergency room. Do not delay. And for the long term, prioritize water intake above all else. Move your body daily. Review your medications with your doctor. Avoid becoming dependent on laxatives. Establish a consistent bathroom routine. And use a footstool to improve your posture when you go. Your digestive health is not a trivial matter. It's deeply intertwined with your energy levels, your immune function, your mental clarity, and your overall quality of life. And yet it remains one of the most consistently neglected aspects of senior health, because people are too embarrassed to discuss it. Well, We just discussed it. And I hope you feel better informed, less isolated, and more empowered to take action. If this helped you, please hit the like button. It genuinely helps this information reach more people who need it. Share it with someone in your life who you think might benefit. Leave a comment below with any questions, and I'll do my best to address them. And subscribe to this channel if you'd like to keep receiving clear, candid senior health education that doesn't talk down to you and doesn't withhold the important details. I'm Dr. Dan Carter. Take good care of yourself, drink your water, and I'll see you in the next one.